This is Chapter 19, Endocrine and Hematologic Emergencies, Part 1. The endocrine system is not something we often think about causing 911 calls, but we have to recognize that the endocrine system influences everything within the body. It is a chemical system that affects every cell, organ, and body function that we have. Endocrine disorders have many signs and symptoms, and just kind of like everything else, we have to, break it down and start investigating to make sure we are treating for the right reason. Hematologic emergencies are difficult to both assess and treat because we don't really have tests. And as a result, you have to be smart and you have to look at those signs and symptoms, try to find them and treat appropriately. The endocrine system is a communication system in the body that relies on hormones to send messages to tell body functions that what changes need to be made in order to support life. One of those is glucose and the metabolism of glucose. The brain requires glucose and oxygen. Cells rely on glucose for energy, and insulin is necessary in order for that glucose to be absorbed into the cells. When our body does not generate enough insulin to absorb the glucose that we need, cells do not get the energy that they need. The pancreas produces glucose and produces glucagon and stores insulin. And we have alpha and beta cells that are in the islet of Langerhans in the pancreas. Alpha cells are what produce the glucagon, and beta cells produce the insulin within the body. And these are some of those chemicals that we rely on to help our body understand what it needs to do. Diabetes mellitus is the impairment of the body that does not allow us to use glucose appropriately for fuel, and it occurs within about 9.3% of the population. Without treatment, people who suffer from diabetes mellitus will see their blood glucose levels become too high. When the blood glucose levels become too high, we do see the potential for life-threatening illness, coma, or even death. Unfortunately, when diabetes mellitus is not appropriately controlled, and even sometimes when it is, you see a patient who will have an increased risk of blindness, heart disease, kidney failure, and other issues. You will need to understand and recognize the signs and symptoms of hyper and hypoglycemia. Hyperglycemia is high blood sugar. Hypoglycemia is low blood sugar. Each can result in type 1 or type 2 diabetics. It can also happen in people who have never been diagnosed with diabetes before. Anyone who has hypoglycemia is going to require immediate and emergent life-saving treatment because we require energy. Type 1 diabetics have an autoimmune disorder where the immune system produces antibodies that break down the beta cells. So your patient is unable to create insulin. Remember, the beta cells produce insulin. Because the body is not naturally producing insulin, without intervention, the glucose will not be absorbed into the cells. We normally see the onset of this in early childhood through about the 40s. So they may not have been born a diabetic, but as they have grown and as the body has started doing what it needs to do, it will start having those issues. And over time, your immune system is going to destroy your ability to make insulin. So what they end up doing is these are the patients who are relying on daily doses of insulin based on how they eat, their body type, their body size, etc., to absorb glucose. So patients will inject insulin and check their blood glucose levels sometimes up to 6 times a day. And we've seen a lot of technology advancements that help in the invasive aspect of this, but it can still be pretty hardcore. We have seen an increase in the use of insulin pumps in our type 1 diabetics. So the insulin pump is an implanted device that is able to continually monitor blood sugar levels and provide insulin that is stored in this pump over time. You don't have to stick your finger as often. You don't always have to inject yourself with insulin. Of course, because it's a machine, you can have a malfunction. So when you're running patients who are diabetics, who have a history, who are type 1, you definitely want to inquire whether or not they have an insulin pump. Type 1 diabetes is the most common metabolic disorder of childhood. And the patients who haven't yet been diagnosed, but maybe have parents who are thinking there might be an issue or there might be a problem, normally see significant changes to the eating and drinking behaviors. So, I know that slide had a lot, but we'll go over them now. And that is polyuria, which is a frequent urination, polydipsia, which is an increase in fluid consumption, and then polyphagia, severe hunger and increased food intake. And here's why. Your patient's blood glucose level will be above normal. So because I'm not producing insulin, I see that sugar level increase in my body. And the kidneys begin to struggle to filter all of that sugar out. Well, because my body's not absorbing it, the only way for me to get rid of it is it to be filtered from the kidneys and released in urine. As that happens, the body keeps going, ooh, you gotta use the restroom. We need to get rid of more sugar. Again, it's the body's way of going, something's wrong. Let's get rid of what we don't like. That increase in fluid consumption is the brain's thought process. A, the more I drink, the more I gotta pee. And B, the more I drink, the more I'm going to dilute my blood and maybe lower that sugar level. And of course, then having a patient who has an increased food intake is a problem. And it's because the brain knows that the cells are hungry. The brain isn't saying, hey, I'm not absorbing sugar. It's just, I don't have sugar. So of course, I'm not absorbing sugar, but I'm eating more, means that my blood sugar level is going to continue to increase. When the glucose is unavailable, when I can't absorb glucose into my cells, I'm going to start burning fat. So I'm going to break down the fat stores in my body, which then creates acid. And that acid waste is going to get into the blood just like the sugar is. So now I've got an increase in sugar and an increase in the acid waste or ketones. Now I cannot maintain the acid-base balance. My pH balance in my body cannot be maintained by my kidneys. Again, this is one of those, as the body keeps trying to recover, it will become exhausted. I will start breathing faster and deeper, trying to reduce the acidity in my blood by releasing more carbon dioxide as I breathe. So remember, breathing releases carbon dioxide. And again, the body's not real sure what's going on, so its theory is, let's get rid of some of the acid in the blood. It must be the carbon dioxide. Breathe more. This increased, deeper, and faster respiration is known as Kussmaul respiration. So it's and these patients, because of the high sugars, they may actually have a very fruity odor to their breath as well. When I don't correct this, and when it goes for a long enough period of time, my patient will be in what's known as DKA, diabetic ketoacidosis. The patient who's going into DKA may originally present as just a generalized illness, complaining of abdominal pain, general body aches, nausea, vomiting, and as they're later into the process, they will have altered mental status and even unconsciousness. When DKA is either not recognized or not treated in a timely manner, your patient will die. So our goal is to get that history of presentation. How long have they been acting abnormally? When was the last time they saw them behaving normally? All those normal questions that we ask, and to get a blood glucose reading. If your patient, we'll kind of talk about this later, but use your patience, but just because they don't have one doesn't mean we shouldn't take a reading. Remember, diabetic may not be diagnosed as a diabetic even up until their 40s, so they may not realize that this may be the first time they've ever had a diabetic emergency. Type 2 diabetes is when a patient is able to produce insulin, but their body is now resistant to the impacts of it. So they are insulin resistant. And what happens is that the pancreas is producing more insulin, and there is an association between obesity and an increase in the resistance to insulin. Unfortunately, we are seeing an increase in type 2 diabetics. And this is when the body produces more insulin because there is an increased level of blood glucose and an inability of those receptors to recognize the insulin and use it to absorb blood sugar or blood glucose. Their type 2 diabetics aren't always going to be put on insulin because it's not that they need the insulin, it's that they need to remind their body how to use it. So a lot of doctors will change the dietary needs and the dietary habits of their patient. They will increase the exercise that the patient is expected to get long before they give them a prescription of insulin. Because again, type 2 diabetics are producing insulin. The body just doesn't remember what to do with it. There are some oral medications that are used with type 2 diabetics. Some increase insulin. So then you've got the potential that if the body does react to the insulin, they could become hypoglycemic. So as we increase insulin, we increase the probability of overabsorption of blood glucose. Others will decrease the effects of the glucagon and decrease release of glucose stored in the liver. So, it will slow the body down, allowing it to use what it does have and not overproducing because it's not working. And we can either use injected medications or oral medications for type 2 diabetics. What normally happens is this is found during a yearly physical, or it's found during a checkup because a patient has a recurrent infection. High sugar levels actually can breed bacteria. So you see patients who maintain high sugar as those who have trouble fighting infection, or they get a reoccurring infection. They may also have change in vision and numbness in their feet. So they've got neuropathy in their extremities. So what is symptomatic hyperglycemia? Well, this occurs when the blood glucose levels are too high. It doesn't necessarily require that your patient be a diabetic, but it is seen often in diabetic patients. Your patient will have an altered mental status, normally from a number of problems along with the high blood sugar. So in your type 1 diabetics, as we've talked about, this is where you've got your ketoacidosis. And because of the excessive urination, as the body has tried to rid itself of the high sugar, and of the acid levels, lower those acid levels, your patient will actually become dehydrated. So there might be some increased fluid intake, but for the urination that is happening as they try to cleanse their body, your patient will actually become dehydrated. And then in type 2 diabetics, we have what's called a non-ketotic hypersmolar state of dehydration. When an individual is hyperglycemic for a long period of time, so it's more than a few hours, we're talking a day or so, or even longer, somebody who hasn't been diagnosed, maybe somebody who doesn't go to the doctor, so they can't be tested, or somebody who has ignored the signs and symptoms, they end up with a high chance of long-term vision impairments, including blindness, wounds that do not heal. This may even lead to the need for amputation because of gangrene, long-term infection, renal failure. So as their kidneys work hard to get rid of the sugar and to get back to normal acid levels, it can lead to kidney failure. They just exhaust themselves and quit. And then gastric motility problems. The body's unable to process and move food, which then increases the problems of appropriate nutrition, etc. And these may also be signs and symptoms you find in a patient who knows good and well that they're diabetic, but who doesn't treat it appropriately, doesn't take their medication, doesn't follow doctor's orders. So when you have a patient who has blood glucose levels that are not controlled and they are a type 2 diabetic, they will go into what's called HHNS. This is hypersmolar, hyperglycemic, non-ketotic syndrome. Again, hypersmolar, hyperglycemic, non-ketotic syndrome. Here are the signs and symptoms of HHNS. Hyperglycemia. I'd like to think you'd realize that since it's in the name. An altered mental status, lethargy and drowsiness, severe dehydration, a dark urine, even with an increase in fluid intake, partial paralysis and muscle weakness, and then even seizures. Higher glucose levels in the blood will cause the sugar to spill, as it's called, into the urine. So that if you were to test the patient's urine, which we don't do, you would actually see high levels of sugar in their urine stream. The urine becomes dark and concentrated and thicker. It's hard for the patient's body, the kidneys, to process because there's so much sugar. And it's like molasses, it thickens the blood. And so then you have the problem of this blood is not going to transport oxygen as effectively. And so the patient may become unconscious and have seizure activity, both due to the dehydration and also due to the fact that they're not getting oxygenated appropriately. It is an acute emergency when you have hypoglycemia. It can occur very suddenly, but it can also take time. But when it hits, once the symptoms reach emergent levels, you have got to act quickly. Every cell needs glucose to act, to do, to behave. And that includes the cells that allow for oxygen absorption. That includes the cells that allow for the heart to beat and for the lungs to breathe. And so it's our goal to treat hypoglycemia to ensure that this patient survives. Hypoglycemia can result in any patient, whether they have been diagnosed as a diabetic or not. Some of the causes is when you have a diabetic patient, who forgot that they'd already taken their insulin, and so they take a second dose without changing their eating habits. When I take insulin, which is going to drop my blood sugar, but I don't eat, I'm going to have problems as well. A patient who is hypoglycemic will have a decline in their mental status, and it's likely that they will become aggressive or at least display some unusual behavior. When this happens, you will see unconsciousness and know that there will be permanent brain damage that can follow quickly. I can't stress enough, the goal here is to get the sugar levels up so that there is energy in the body to do those actions that are life-threatening and that will maintain life. Why do we have low blood sugar? Well, someone who has the correct dose of insulin, but a change in routine. So they take the right insulin, but they skip a meal, or they've increased their energy level. They take too much insulin. So they're eating their normal levels, but they have increased the amount of insulin in their body. They don't eat enough. They take the correct dose and they're eating appropriately, but they have an acute illness that is causing their body to use more energy to fight off the illness that they are suffering from. In some instances, hypoglycemia will occur in minutes. There will be a rapid and sudden decline in the blood sugar. Opposite of hyperglycemia, which does take time to see an increase in blood sugar levels. So hypoglycemia can be much more sudden onset than hyperglycemia. What are some of the signs and symptoms beyond that level of consciousness and mental status change? Normal to shallow or rapid respiration, so a change in respiratory effort. Pale, moist skin, sweating, dizziness or headache, rapid pulse, and then a normal to low blood pressure. Hypoglycemia can be viewed as a form of shock. We've got that altered mental status, that anxious or combative behavior, seizure, fainting, unconsciousness or coma. They may have weakness in their body, sometimes on one side as the brain is slowly dying and you're seeing brain tissue not get appropriate oxygen and sugar levels. And again, rapid changes in mental status. Hypoglycemia is quickly reversed by giving them glucose. So we can give a drug to assist these patients as long as they meet the appropriate criteria. And the box that you see on the screen here shows you those levels. So 80 to about 100, 120 is going to be a normal blood glucose level. Anything below 80 is going to be seen as hypoglycemic. Anything above 120 is going to be hyperglycemic. When a patient reads 400 or above, we are in DKA or HHSN. That is hyperglycemia to the max. That's extreme. And 40 and below is hypoglycemic. Most of our blood glucose monitors in the field may just flash low or high at a certain point. I've seen it at 499. I've seen it down in the 30s. So, when it doesn't even register a number, you've got a patient in severe crisis. Our hypoglycemic patients need quick treatment. Hyperglycemics we'll talk about. There's not a lot that we can do, but regardless, we've got to act fast for both of them. So it is a medical call, and we will start with the standard medical scene size up. BSI, being cautious because if they are diabetic, if they've taken insulin, there may be some syringes or some needles from blood glucose checks. You've got to make sure that you're asking the bystanders or family members questions, because if the patient has an altered mental status, you need to get the data from somewhere. Looking at the MOI versus the NOI. wearing appropriate PPE. We're going to form a general impression. How do they look? How does the scene look? What do you feel this is? A high or low priority? How does it make you feel? And then moving into airway and breathing. Are they breathing enough to sustain life? Is that breathing rate, rhythm, and quality appropriate for your patient? Look at that oxygenation. Is there an altered mental status? If they meet the requirements, give oxygen via non-rebreather, 12 to 15 liters per minute. We've got to remember that they may have that sweet, fruity smell in their breath if they're diabetic. And don't assume it's because they're diabetic. It's possible your patient just finished a cough drop or a piece of candy. So ask, have they eaten recently? This is where that interview comes in. And manage your respiratory distress. Signs and symptoms occur in the respiratory system for both hyper and hypoglycemics. So we have to recognize that these patients may need a bit more ventilatory support. Check the circulation, especially skin color, temperature, and condition. Dry, warm skin is expected in your hyperglycemic patients, and moist, pale skin in your hypoglycemic patients. Also remember that there are going to be pulse changes in our patients, with your hypoglycemic patients having a rapid, weak pulse. And of course, the problem here with that is the faster the heart beats, the more glucose it needs to function. Make a transport decision. If your patient has an altered mental status and is unable to swallow, whether it's because they can't follow commands or they're unconscious, they're going to be a high priority patient. If your patient has an altered mental status, they're a high priority, whether or not you think they can swallow. If they're conscious and able to swallow, you might want to wait, because in reality, hypoglycemics who are treated are likely to want to refuse care, and if they need it, they can. So being halfway to a hospital when they wake up, probably not the best idea.